guys, I'm Ashka, class president, so if you guys need anything in terms of communication with the professors or anything in general that comes up, any issues in between labs or conflicts or any questions that you have in regards to exams or whatever's coming up, feel free to reach out. And if you want to talk, if you're having any trouble or need any help with studying, I'm always here. So nice to meet you all again, and looking forward to a good 2 years.
For those that don't know me, Casey, I'm Vice President. If you have any problems whatsoever, ask Oscar.
Oh.
Hey. All right, what's going on, guys? I'm Devin. I'm going to be the bearer of bad news. I am your treasurer, so I will be collecting those dollar bills. So let me know if you have any questions as well, and we'll get a class Venmo set up, and we'll go from there. We're thinking we're going to set dues at around $25 to $35 a semester, but that's always negotiable via the class. But again, feel free to reach out.
So guys, I'm Steven. I'm your secretary, so I'm going to be taking good notes for you guys. I'm always going to do it on Google Docs. I'm going to share it on the Google Drive. If you guys want to take notes on your laptop, I just made it for today, and I will for every lecture. If you guys want to chip in, take your own notes, you can modify it as we go, or you guys can just look at it after class, whatever you feel like. If you guys have any concerns or questions about the notes specifically, you can contact me, and anything else, like he said, just contact me.
Take notes, make his life easy.
Just a quick thing about like dues and stuff. We're still working that out, just the 5 of us. And sorry, Dave is our class rep. I'm sorry.
Yeah, Dave.
Well, Dave, introduce yourself.
I'm Dave. I'm the class rep. Since we kind of have to split up into 4 groups, I'm thinking we try to be responsible for making sure everyone kind of stays on the same page, and all the different labs, end up going over the same stuff, and all of our notes kind of line up. So if you have any questions or want to kind of look at the notes from another lab, let me know. I'll help you out.
And we're still figuring out like some details with stuff, so we'll definitely keep you all updated. We are planning a couple of fundraisers just to kind of keep up, because everything that we do goes towards our graduation at the end of the 2 years. So we want to make sure we have enough funding for all of that fun, exciting stuff. So we'll obviously keep you guys all up to date with what we're planning to think about. And if anyone has any ideas, please feel free to chip in.
Sweet.
Okay? All right. Now, any questions about soap notes? I know we didn't really, I'd rather do this. I mean, we can always go back to soap notes. Oh, sorry. But I'd rather start this. As we start doing soap notes, it'll get easier for you guys. So basically, if we think about a soap note, we think about the subjective, the objective, the assessment, and the plan. And I wanted to clarify also something. In these days of being politically correct and politically incorrect, many years ago, I told you that I said to somebody, 10 being the worst pain in the world, like you had to jump off this building. Don't use that example, okay? I used that example many years ago, and it's not something that, people probably wouldn't be very favorable to that, and you really don't know your patient. If you're just working with a patient and you say on a scale of 1 to 10, please report your pain, 10 being the greatest pain you ever experienced, 0 being no pain. Okay? So if a patient said, you say to the patient, how do you feel today? And they said, I'm wondering if I need to keep this on being 6 feet, no? Okay. Is it easier to hear me?
Yeah.
If a person is, if you're working with a person, you say, how do you feel today? And they said, I have a lot of pain in my leg. And so then, to be more specific, you could say to them, on a scale of 1 to 10, what is that pain? 10 being the worst pain you ever felt in your life, and they say 5. So for subjective, you'd say, patient reports a 5 out of 10 pain in the right leg today. And remember, I also said you're not going to quote a patient verbatim when they say things like, that other therapist I had, I really hated her, and you're so much better. You could say something like, patient reports difficulty with therapy prior to reporting to this facility, something like that. Okay, you don't want to You don't wanna bash anybody, you don't wanna say, if they say that their doctor stinks, that the doctor stinks, patient reports, inability to communicate with their physician, something like that. So we wanna be pretty specific in what we say, we also wanna be politically correct, okay? And your objective is measurable. What did you do? Did you provide the patient with a home exercise program?
Sorry.
Did you measure a patient's range of motion? Did the patient ambulate? So it's based on time, it's based on, are you leaving, or you guys aren't doing it, or? Are you guys doing practice today?
I'm not staying now,
Yeah, after.
All right, and is my office locked?
Lindsay?
Do you guys have access to the notes on the Google Drive?
It's locked. Okay, so when I'm done, I'll come back and unlock you, or whatever.
Should
If
on
you
the
want to be in my
website.
office, I'll unlock it for you.
I can't stay.
Yeah, it should be
Oh,
on
I
the
thought the
website.
students were staying.
I
What's
thought
that?
they were staying right
I put
now.
9:15.
Okay.
Need a
all right.
second for today.
Okay, so how many times, 3 reps of 10 with a contact guard of 1, 3 reps of 8 with minimal assist of 1. We have to be really specific in what you have done with this patient and what this patient, what is measurable. What have you done with the patient? What have you found? Balance is impaired. Well, how is it impaired? It's minimally impaired. Well, what does minimally mean? So a patient is unable to maintain a standing position in your assessment. Patient is unable to assume a standing position for 1 minute without losing balance, something like that. So it'll get easier over time when you guys write SOAP notes. But we will ask you to write a SOAP note after every practical exam. Not a bone practical or a muscle practical, but anything where you physically have to work with a patient, yes.
For the first lecture exam, are like laws and ethics and SOAP notes going to be on there, or is it going to be mostly clinical kines?
Be mostly clinical, but there'll be questions about SOAP notes in multiple format. And probably, I think maybe next Thursday, I'll give you a test, but not a lecture multiple choice test, but a written test.
Will you get content?
Based on what we've done up until now, so it'll be definitions of minimal, moderate, max assist. I may ask you, how do you transfer somebody with minimal assist who has a total hip replacement on the right? I may say, what are the 5 Ds, and including everything that we cover here.
Okay, cool.
Okay, so probably next Thursday.
Including
Put it on.
the laws and
Yeah.
ethics lectures from Professor
We'll give you
Bailey.
some scenarios of a patient scenario and ask what laws are violated, or what ethical principles. Okay? Probably next Thursday. Okay. And I'm keeping this because I don't want to keep turning around, because if I keep turning around, then you can't hear me. So, what is kinesiology? Anybody? Anybody know what kinesiology is?
Study of movement.
Yeah, it's a study of movement. So it's a combination of a lot of things, right? Anatomy, you have to know your anatomy, your physiology, geometry, because there's angles, physics, all this stuff as it relates to movement. So that's the definition of kinesiology. So before we even talk about the kinesiological definitions, we'll talk about a few definitions that we need to understand when we're working with the patient. Anytime they have anything going on in their life, I mean, you have experienced yourself. Think about that patient that has walked across the street or ran across the street after a dog, or got hit by a car, lost a leg, lost an arm, lost an eye, whatever, got shot, was in the wrong place at the wrong time. I mean, anything, was in the World Trade Center. I mean, anything, any kind of trauma. Their initial stages are shock, so this person will exhibit shock, and we'll learn the signs and symptoms associated with shock at a later date. But this is normal, followed by denial. Denial can last several days and can last a couple of weeks, right? So, it really didn't happen to me. I'm going to fall asleep and I'm going to wake up and my leg's going to be there, right? I'm sure you've done this yourself. Well, this really isn't happening to me. This is all a bad dream. Right? It's not as bad as it looks. It's going to be okay. So these are all stages of denial. Then mourning or self-blame. That self-blame saying something like, well, you know, my mother told me not to go out that night. I'm 15, 14, 13 years old. I shouldn't have gone out because now I'm hit by a car and I lost both legs. Right? Or if I only left for work 5 minutes earlier. Or if I wasn't rushing and I did what I was supposed to do. So all these things you're blaming yourself for. This is what patients do. Then they get angry. So they become non-compliant. Why do they become non-compliant? Because that's the only control they have. They have no control of the situation. What if we talked about today transferring and that paraplegic or that quadriplegic? Think about getting up in the morning, you're a swimmer, you're a diver. You go into a pool or you go into a place that you don't know off a cliff and all your friends say, hey, you're the diver, why don't you dive? And it's 3 foot of water. So what happens? You've just broken your neck. Your cervical spine is broken and you will no longer ever be able to dive, walk, have relations with anyone because nothing is working anymore. Everything is paralyzed. So think about all that. You become angry. You become rebellious. I'll give you a scenario. I doubt if this young man is still alive. I still remember his name, which I won't tell you. But I will tell you that he was a football player. He was 6'8". He was 15 years old. And he was scouted for all conference and all this kind of stuff. The kid was incredible. He had heat exhaustion, and he also was tackled. It's a very, very hot day. He was tackled, and he lay down on the ground. And again, I told you he was 6'8", and the coach came by, noticed he wasn't breathing. He had a helmet on, so the coach took off the helmet. So what did the coach do to the cervical spine? Caused it to go into hyperextension. Okay? He had an incomplete fracture, which became complete at the level of C2. So what's the big deal? What innervates the diaphragm? The phrenic nerve. What's the phrenic nerve come from? C3, 4, 5 keeps the diaphragm alive, right? So the cervical levels of C3, 4, and 5 innervate the diaphragm. So can this C2 quadriplegic breathe on his own? No. In fact, they had to put in a phrenic pacemaker. This 15-year-old, 6'8" young man, I had to go up and see. When I walked in the room, and these were the days when they used to leave the windows open, a fly was on his nose. He could move nothing but his eyes and a very little bit of his head. So when I came in, I wanted to swat the fly away from his nose, and he said to me, leave it there. Leave it there. Don't touch me. Because this was the only control he had. So that's just an example of the fact that someone becomes rebellious, or they become angry, or they become distant, or they're not the person they were before. Okay? And then I said to him, I have to move your leg. Now, the reason why we have to move these people is because they need eventually to be able to be transferred to and from a sitting position, right? What happens if you lie in supine all the time? You start to develop joint contractures. You also start to develop pressure sores. This kid had a pressure sore like this on his occiput. And it started to smell. and only then would he let me move his head. So you have to recognize a person's autonomy, but you have to also recognize their safety. So we got to the point where I said I could no longer, I have to touch you. I have to touch you, I have to move you. And that was when we started to have some kind of a relationship, but not much of one. Because shortly after he was transferred from an acute care facility to a rehab place. So these things happen, and you're gonna see them. And then finally, you start to get into, okay, I accept this. There's a resolution period that goes along. All right, I realize this is the way I'm gonna be in my life. Let me try to turn it to a better thing. Those of you who watch some TV and maybe watched, did any of you watch, there was an article, a thing about, a 60-minute thing about somebody, an architect who became blind? He became blind, lost his vision, like in a night. And he was an architect. So what do you have? Architect, you have plans, you have to see, you have to write, you have angles, you have to draw. He said he could walk past buildings and recognize which building didn't have the right overhang, which building needed to be angled differently after he became blind. So in his words, this blindness was a blessing in disguise to make him a better architect. There's not a lot of people like that in the world, right? Most people, what would you do? You'd kind of crawl up in a ball and say, I feel sorry for myself. That's a normal thing. But then people accept it and they turn their life around. Okay. All right, so when a patient, and know that they can go through these 5 steps of grief over again. So you saw them one day, they seemed to accept it, everything seemed great, and then the next day, something happens again. I have so many stories about this because I work trauma, so I work inner city. I had this young couple that went on a honeymoon, and they went parasailing, and his parasail broke, and he became head trauma. Not only head trauma, but he also became paralyzed. They were on their honeymoon. So, of course, what did she say? I'm going to stay with you forever. Did she?
No.
Can you blame her?
No.
No, because the guy was no longer the man she married. He was head trauma. He was never going to come back from this. He had lost. Part of the brain wasn't working the way it used to work. He couldn't speak. He couldn't eat. He couldn't feed himself. And he couldn't control his bowel or bladder. So for a while, she stayed with him in the same bed. And then she got to a point where she said, I have to admit him into a facility, a nursing home. He's 25 years old. These things happen, and you will see them. So there are times when you have to go into a room and you have to talk to patients, and you have to be a good listener. Okay? You can't sit there and say, I know how you feel. I never said that to a patient. I would say, I don't know how you feel. Because you don't. You're not in that situation. I mean, I could say to somebody who had a knee replacement and a realignment, I know what it feels like because I've been there. But you can't to someone who fell out of a tree, dove and broke their neck in a pool, had half their head shot off. You know, you don't know how that person feels. So some of the times, all you do is listen to a patient. You know, you may be with a patient for a half hour, but 20 minutes of it might be you listening to this patient because you're the only one that is going to listen to them. Doctors don't have time. Nurses don't have time. So, and as you could see from what we're doing, even as far as transfers, we get up close and personal with our patients. We touch our patients. Okay? So, I want you to remember that. And if you don't know an answer to a question, refer them out. Okay? A lot of times patients say, well, will I be able to have children? Because I'm paralyzed. Will I be able to have children? Well, I can tell you they can. But, you know, at this point in time, as students, you don't know this. So you say, well, you know, we're going to have to ask the therapist or we're going to have to ask your physician. That's a question better suited for your physician. Something like that. Okay? But they will ask you everything and anything. And if you know, you can say. If you don't, and a lot of times patients say, can I walk again? Will I be able to walk again? And they're paralyzed. That I would refer to the physician. What has the physician told you? The physician has your diagnosis and has your special tests, etc. Once the physician has told the patient and the patient knows that they will not be able to walk again, or they've heard it from somebody, then you could say, you don't want to be the first one to say to the patient, no, you will never walk again. I've also had patients that a doctor has said they'll never be able to walk again, and I think I told you about this guy. He was a Claude he was shot. He lost an eye. His grandfather shot him in the eye and shot him in the back. And he was a huge guy. And I was on the bed with him, and I was stretching out his leg, and I was doing like a contract relax thing, and I found fasciculations in the hamstring, so I know that he had an S1, S2, that was still innervated. And the doctor said to me, no, this guy has nothing. He's completely paralyzed. He's a complete paraplegic. But he wasn't. Because I said, I documented fasciculations, and he called me on the spot, and he said, why are you writing this? This is not happening. I said, it is. And the kid was able to walk with lost chair and crutches. So, but I only document what I found. I didn't make up things. I documented what I found. I talked to the physician about it, etc. Okay? So, descriptive terminology. Anatomical position. The anatomical position is one where the heels are together, the palms are up, toes are pointing out. So this is the anatomical position. So when we talk about the anatomical position, as opposed to the fundamental position, fundamental where the arms are at the side. Okay? So anatomical is like this, right? So when we talk about planes of motions, we always talk about them from the anatomical position. Okay, so what is closest to my body is medial. What is furthest away is lateral from here. So this would be the medial portion of my forearm, and this would be the lateral portion of my forearm. Hence the lateral epicondyle and the medial epicondyle. So we'll always refer to things from the anatomical position. Superior is toward the head. It's also known as cephalad. And caudal is toward the feet. It's also known as inferior. And when we say superior and inferior, we always refer to the trunk. Any of the extremities, when it's below or above a joint, we refer to it as distal or proximal. Okay, so the C2 superior articular facet is inferior to the C1 inferior articular facet. Okay, my olecranon is distal to my glenohumeral joint. Okay, you get it? Anterior is also known as ventral. So this is the anterior trunk, or the ventral surface, or the anterior palm, or the ventral palm, or the palmar surface, or the posterior palm, or the dorsal surface. Okay, so anterior is ventral, posterior is dorsal. Medial is closer to the midline, lateral is further away from the midline. Proximal, again, closer to the trunk, distal, further away from the trunk. So my glenohumeral joint is proximal to my humeral ulnar joint. My radiocarpal joint is distal to my humeral ulnar joint. Okay? When we talk about planes of the body, we talk about planes and axes. Okay, so these are fixed lines of references, and there are three planes, and they're at right angles to one another, and they're perpendicular to their axes, because movement occurs in a plane through an axis. Okay. So the mid-sagittal plane divides the body right to left equally. Okay, so if I were to take a saw and I were to cut myself right here, I would be making a mid-sagittal plane dissection. Okay, as opposed to like right here, to be sagittal plane. But mid-sagittal, I'm dividing my body into right and left equal halves. Coronal or frontal will divide the front and back of the body. So if I do a coronal cut, I cut through here. Okay? And transverse or horizontal divides the superior from the inferior. Okay? And as I said before, axes are perpendicular to the planes, and they run through the center of the joint, and movement occurs around an axis. Okay. Types of motion. With linear or transitory, that's usually referred to as straight line, occurs in a straight line. All parts of the object move at the same time, the same direction, and the same distance. And your book gives you types of motions, straight line movements, known as rectilinear or curvilinear. Now, rectilinear is truly just in a straight line, like a sled going down a hill. And your book gives an example of diving as a curvilinear motion. So it's in a straight line, but it's curved. Most of the motions in the body are angular, but we have some rectilinear components to it. Joe is a skateboarder, so when he goes on a skateboard, hopefully he's going in a straight line to begin with. So he's going along on a straight line, which is a linear or rectilinear movement or a transitory movement. But as he's taking his foot up and down off that skateboard to push, we're having angular or rotatory movements occur at the joints that he's using to get from part A to part B. Okay? So with an angular or rotatory motion, all parts of the object move at the same time, same direction, don't move the same distance or same speed. So think of if I'm lying on my stomach and I'm moving my knee through range of motion. The proximal part of the tibia is not moving as far as the foot to get that knee flexion motion. Okay? So here the knee doesn't move as far as the foot moves the furthest. And as I said, most movements in the body are angular motions. Osteokinematics refer to bone, as opposed to arthrokinematics, which refers to joints. Okay? So if we look at osteokinematics, it's movement around a joint axis. So movement of this limb around a joint axis. So it looks at the motion, and we could talk about things like shoulder flexion and extension, shoulder abduction and adduction, shoulder internal rotation and external rotation, okay, internal rotation and external rotation, shoulder horizontal adduction and abduction. So these are osteokinematic movements, as opposed to movement of joint surfaces, and that's known as arthrokinematics. So if we think of the glenohumeral joint and we think of the humerus moves in one direction as we have an osteokinematic movement of flexion. The bone is moving up, so the roll of the humerus is in the same direction of the movement, so it's moving up. But if I keep rolling that humerus without gliding it in an opposite direction, the head of the humerus will just come right off the glenoid. So we have to have a glide movement, which is opposite in direction to the rolling of the movement. All right, that's joint mobilization. There's a concave-convex rule that we'll talk about. When we mobilize a joint, we have to know, is the movable surface concave or convex? Okay, so concave means this, and convex means this, right? Concave looks like a cave, convex is a ball, so the ball is in the socket of the glenoid. Which is which? The humerus is convex, the glenoid is concave. Yes?
Yeah.
So if I roll in an upward direction, so I'm rolling, here's the ball, here's the bone, rolling in an upward direction. If I keep rolling, it's going to come off. So as I roll, I have to glide. So I'm rolling and gliding at the same time in order to cover the surface area without falling off. I'll explain this a little bit more when we start to talk about mobilization. I just want you to get the concept of gliding, and it also spins, so it rotates on itself. It spins in the axis. So when we talk about arthrokinematics, we talk about the rolling, the gliding, as well as the spinning. Okay? So what's the difference between kinematics and kinetics?
Kinetics are the forces causing movement.
Yes. Kinetics are the forces that cause the movement, and the kinematics looks at the motion. It describes the motion. Okay, or it looks at the motion without really describing it. It's time, space dependent, and looks at mass. So if I looked at a kinematics, I would look at flexion, extension, abduction, as opposed to the forces that are occurring around the joint or the torque that's involved with the movement around the axis. Okay. So, arthrokinematics. You could have at the joint surfaces, you could have a roll, which new points make contact with the surface. Think of a ball rolling. New points of the ball are making contact with new points of the surface as you roll it. Spinning, the same point remains in contact with the surface, and gliding is one point on one surface contacts another point on another surface. Okay? So when we talk about rolling, now that's getting too advanced. But just know that the arthrokinematics of any joint involve all of these things: rolling, spinning, and gliding. What we will be interested in for joint mobilization is the roll and the glide, because that's what we have to determine in order to get movement in the direction we want. All right? I'm going to show you this in lab because you guys need to feel this. All right? I mean, you could see it, but it's a lot easier to feel. Yes?
Just out of curiosity, like, what's an example of a joint that spins?
Every joint spins. Yeah. You have rotation in every joint. Yeah.
Like blow and flow and stuff.
Well, almost every joint. I shouldn't say every joint. But joints where you have rotation, you have spinning. Okay, but these are the arthrokinematics. So, what are the definition of any of these things? What's flexion? Flexion is decreasing an angle between two joints, okay, between two bones. So decreasing an angle between two body parts or two bones in a sagittal plane, and what did I say? That planes and axes are perpendicular to one another. So what's perpendicular to the sagittal plane? The coronal or frontal plane. Okay, so that's the axis. So flexion or extension of the shoulder or of any joint is decreasing the angle between two bones in a sagittal plane through a coronal axis. Okay? In a sagittal plane. Can I have a piece of paper? You just. And just have a pen and a pencil. So this is flexion or extension of the shoulder. Here's the arm. Flexion, extension. Flexion, extension. Here's the axis. Okay? So remember I said cut me from anterior to posterior? And that's a coronal or frontal axis. And movement occurs in the sagittal plane about or around a coronal or frontal axis. Okay? As opposed to abduction, what plane am I moving in? Coronal or frontal about a sagittal axis. Okay? And then finally, horizontal the movement is through the transverse plane within the vertical axis. Okay? So these are the definitions. And you guys should know this. So flexion, decreasing the angle between two body parts in a sagittal plane through a coronal axis. That's this, flexion. This is extension, all right? In your A&P classes, you learned that this was hyperextension, right? You learned that this was hyperextension because extension is always returning from flexion. In the PT world, we call this, especially when we measure it, shoulder extension, cervical extension. All right, the terminology is just a little bit different, but it means the same thing. Okay? So flexion, extension. Flexion, moving in the sagittal plane through a coronal axis. Abduction, movement in a coronal plane through a sagittal axis. Okay? Flexion, because we look at things from the anterior surface too, with the trunk. Trunk flexion, cervical flexion, cervical extension. Trunk flexion, trunk extension. Hip flexion. I'll use the other leg. Hip extension, right? Hip flexion, hip extension. Just plain hip flexion, hip and knee flexion, right? With the ankle, we say dorsiflexion and plantar flexion. Okay? Wrist flexion, wrist extension. You got it? All right. So these are just the definitions. Flexion, decreasing an angle between two body parts in a sagittal plane through a coronal axis. Abduction, yes.
How would you define hyperextension?
How do we find what?
How would you define it?
How would you define what?
Hyperextension.
Hip extension?
Hyperextension.
Hyperextension. Hyperextension is extension past neutral. That's generally how you refer to hyperextension. I'm just saying, in the terminology we use as PTs, we call this cervical extension, especially when we do range of motion. When you do range of motion and document it, a PT will never say hyperextension of the cervical spine, because hyperextension indicates to us that there's something wrong. Devin has hyperextension of the elbow, I noticed today. Yeah.
Cool.
Can you extend your elbow? Yeah, there you go.
Right left.
Yeah. So he's got hyperextension. So that's extension past neutral. But that's abnormal. So that's a pathology. You know, maybe some ligament laxity. I mean, for him, there could be all kinds of things. It could be a systemic reason why that's occurring. Or
Two
could-
double hits and
you
hockey
could-
coming this way.
You could have had, you could have had an anomaly, or you could have had an injury. I mean, we don't know until we examine it. So, but that's a good question. Okay, so hyperextension, extension past neutral. So abduction, movement away from midline of the coronal plane or frontal plane through the sagittal axis. Abduction, so this is abduction, this is adduction. Okay. External rotation. External rotation is lateral movement, transverse plane through the vertical axis. So this is external rotation. This is truly external rotation of the glenohumeral joint. Okay? This is truly external rotation. This is internal rotation. Can I do it this way? Sure. But then I have the scapulothoracic joint to look at besides the glenohumeral joint. Okay? So I'm looking at the whole shoulder complex and not just the glenohumeral joint. All right? But is this internal rotation and this external rotation? Absolutely. Okay? But we have to know what joints are doing what. And that becomes really important when we start to do passive range of motion and mobilization. Because if somebody's got a problem in their glenohumeral joint, and I start mobilizing the scapulothoracic joint, it's going to do nothing for their shoulder. Okay? So we have to know what joints are moving. So for next week, if I say to you, name a joint and describe a motion that occurs at it, you could say glenohumeral joint. The motions that occur, flexion, extension, ab and adduction, internal and external rotation. Okay? Okay. And we said, yes,
What circumduction is that?
circumduction are movement through two planes of motion, flexion, extension, and ab and adduction. That's circumduction. So what has the ability to circumduct? Your hip. your shoulder, your thumb. We have circumduction. So we have 2 planes of motion.
For like the question example you gave us, would we have to name the planes as well that those movements occur?
Yes, yes. All right, what's supination of the forearm? Palms up, okay? Supination occurs at the proximal radial ulnar joint, okay? So supination occurs right here. Proximal radial does not occur at the elbow, all right? Occurs at the proximal radial ulnar joint. So supination, palms up like you want some soup. Give me some soup, okay? Pronation, palm down, which is different than feet, because there's supination and pronation at the foot, which gets a little bit more complicated. So, proximal radial ulnar joint, supination and pronation. Ulnar deviation, and I'll show you for here. I would show you in the here, but I don't think some of you, can you all see me from up there when I'm doing my wrist? So I'll do it this way. So this would be ulnar deviation to the ulnar side, and this would be radial deviation to the radial side. All right? But if I do it in the anatomical position, it's adduction and abduction, right? So if I were taking an A and B class, they would say wrist adduction, wrist abduction. But it's ulnar deviation and radial deviation. Okay? Yes?
In the anatomical position, is it also ulnar and radial?
Yes.
But
yes.
everywhere else, it's
Yeah.
only.
But as long as you know that if somebody says wrist adduction, you know they're talking about ulnar deviation. Because if I adducted my wrist here, it would be radial deviation. So that's why I'm saying you have to do it from the anatomical position. Okay. All right. Circumduction, we said 2 planes of motion: flexion, extension, abduction. Internal and external rotation do not occur with circumduction. It's 2 planes. All right. The thumb is the exception to the rule when we talk about definitions. Okay, watch me. This is thumb flexion. What plane is that? This is thumb flexion. Frontal, coronal. This is thumb abduction and adduction. What plane is that? Sagittal. So the thumb is the exception to the rule. Okay, thumb flexion and extension occur in the frontal plane. Thumb AB and adduction occur in the sagittal plane. That's an exception. Yeah.
Does the head circumduct, would that be a movement of the head as well, circumduction?
Sure.
Okay, just making sure.
Circumduct the head.
So it's hip, shoulder.
Well, you kind of rotate the head. You don't really, no, you cannot circumduct the head, you rotate, because rotation has to be part of it. See, if you just do lateral flexion and abduction and flexion, you can't go in a circle. That's rotation. And that's not part of what circumduction, the definition of circumduction.
Did you say the ulnar deviation and radial deviation is on the frontal plane?
Ulnar and radial deviation are what?
On the frontal plane?
Ulnar and radial deviation, yes. Movement in the frontal plane. Yeah. Okay? And do we truly, we'll learn when we do PNF, which is proprioceptive neurovascillatory techniques, that we don't move in these planes. I mean, when we perform motion or with a patient, especially passive range of motion, we better stay in the plane because we need to restore the movement in each plane. But when you say hello to somebody in the street, do you say, hi? No, you say, hi. So you're kind of moving through all planes, right? And that's really based on what we do in PNF, proprioceptive facilitatory techniques. We move in patterns. But when we restore motion, we have to stay in the planes, okay? Because if we go out of the planes, then we miss the joint that we're working on. Opposition is this. Okay, so we can have thumb to fifth finger opposition, fifth finger to thumb opposition. Okay? So that's opposition.
Both finger and thumb into each other, right?
Yeah.
terms of staying within the planes, you're doing an assessment, doesn't it also become harder to make documentation of that? Like if you're going in and out of planes, you're trying to find like how much they're able to, the degrees of motion, right? And you're going all over the place. It's harder to make an objective assessment.
Absolutely, because if somebody's supposed to have 180 degrees of shoulder flexion, which functionally we have about 165, if that's normal, and we do this, I'll do something, you tell me what I'm doing.
Shoulder height, shoulder flexion.
What I do,
Shoulder elevation.
what I do, what I do.
You elevated your shoulder blade.
I elevated my shoulder. So I didn't do true glenohumeral flexion. I did scapulothoracic movement as well as glenohumeral flexion.
You were showing.
Because I could not get full range of motion in my shoulder. I did that purposely. So I didn't do this, I did this, right? I really want to exaggerate it now. That's different. But it means a whole lot. Because if you're working on person's shoulder flexion and they keep doing this, it's just like you see them on those stupid finger, I hate those things, on the wall. They say, oh, do the finger ladder, it's good for you. So a patient does this, or else they do this. How is that increasing shoulder flexion? It's not. It's not.
So women getting up on activity
Yeah.
days to get hired or.
Yeah, and they're so proud, and but they're doing nothing. So, all right. Types of skeletons. So axial skeleton. Axial skeleton is upright skeleton. There's 80 bones in the axial skeleton, 126 bones in the extremity. So altogether, how many bones do we have? 206 bones, right? So what's the importance of the axial skeleton? And you can see the axial skeleton here, as opposed to the limb girdles. The limb girdles are all part of the appendicular skeleton. So where is the hyoid? It's part of the axial skeleton, right? The ribs are all part of the axial skeleton. Anything that's on the girdles of the limbs are appendicular, important for movement. So 206 bones, the axial skeleton, some of what comprises that, I have there the skull, the hyoid, vertebral column, all parts of the axial skeleton. Ribs, sternum, coccyx, as opposed to appendicular. Some of the things can include are the clavicle, the scapula, humerus, radius, ulna, carpals, etc. So the limb girdles are all part of the appendicular skeleton. What's the function of the axial skeleton? It's one to support, right? Remember we said we need a stable core with which to operate our limbs, our extremities. So we need movement as well as stability. And the axial skeleton also protects our internal organs. It's also important for the formation, manufacture of blood cells. So that's hemopoiesis, manufacture of blood cells. And that happens at the proximal ends of bones, femur, humerus, as well as the vertebra, the sacrum, so the ribs, that's where hemopoiesis occurs. And appendicular is for locomotion. So, again, I said we need a stable core in order to move our limbs appropriately and effectively, efficiently.
Professor, is it hemo or hematopoiesis? Or is that the same thing? Hemopoiesis and
Hematopoiesis, same thing. But hemopoiesis is they use the terms interchangeably, but physiologists use hemopoiesis. Okay, so what kind of, so we know we have these bones, and we're going to spend very little time on this. But what is bone? Bones consist of both organic, so we have living and we have non-living. So the third of the bone is living, and that produces the elasticity of the bone. And 2/3 of the bone is inorganic, and that provides the support as well as the strength of the bone. So we have this compact and cancellous bone. Compact bone is in the shaft around the cancellous bone. Compact bone is dense. It's highly innervated, it's hard, it's thinner at the ends. It has periosteum, the compact part of the bone, and it has a nerve supply, so it's highly innervated as well as has a blood supply. The cancellous bone is within the epiphysis. It's the inner part, it's spongy. It's also filled with something, the sponginess is also filled with something called trabeculae, and that's filled with the bone marrow that's in the long bones. So it's porous, it's lighter because it's filled with marrow, so it's not as, it doesn't feel as heavy as dense bone. The diaphysis actually is the shaft of the bone, the epiphysis is the ends of the bone. We have an epiphyseal plate and epiphyseal line, and this is all kind of just review. The epiphyseal line is something that is seen after a bone matures, and I guess after, some of the physiology instructors will tell you that, a female matures earlier than a male as far as bone closure, but the only way really to tell if you have epiphyseal plates or epiphyseal lines is by x-raying. So at the point of closure, if you see an x-ray, you'll see an epiphyseal line. So, metaphysis is that flared part of the bone, or the neck. It's that flared part of the bone in the long bones, and it actually supports the epiphysis. I said that the epiphysis at the end of is osseous in adults, and it's at the end of the bone. Endosteum is what covers the medullary canal, and it contains osteoclasts, and the osteoclasts are important for bone reabsorption, as well as osteoblasts. So osteoblasts make bone, osteoclasts break it down for reabsorption. Periosteum, I said, is on the outer layer of the bones, the outside. And again, I said that the periosteum is really important because it contains blood vessels as well as nerves. So it hurts. It hurts when you break a bone. If you don't believe me that the periosteum is highly innervated, then turn to your partner and kick them really hard in the shin. It's going to hurt. Okay? And it's really important, the periosteum is also important for nourishment of the bone itself, and it's also the attachment for the tendons and the ligaments, attaches to the periosteum. So here we just have some pictures, structure of the bone. The epiphysis responsible for growth, so the epiphyseal plate then becomes the epiphyseal line once growth stops occurring. Endosteum lines the inner part of the medullary of the bone, the medullary cavity, and the trabeculae are found in here, spongy bone. Periosteum is the outer coating. The metaphysis is the flared part, and the epiphysis are the ends. So growth occurs, longitudinal growth occurs in the epiphysis. Okay. Let's see. This is the same thing we just said. Same thing we just said. Same thing we just said. Okay. So, let's go to types of bone. There's a long bone where you have a diaphysis and two epiphysis, one on each end. Long bones are things like femurs, phalanges, humerus, ulna. These are all long bones. Then we have short bones, can either be the carpals or the tarsals, and we talked about what the carpals and tarsals are. How many carpals do we have? 8. And how many tarsals do we have? 7. Okay, they usually articulate with more than one bone, and that's what happens with the carpals and the tarsals. Flat bones are usually broad and they're thin, so something like flat bone might be an ilium, the sternum, the scapula. Irregular have mixed shapes, and in some books, I will never hold you to this because some books say some bone is irregular, and some people say scapula is flat, some people say scapula is irregular. So the vertebra, the sacrum, and types of sesamoid bones are located either in the foot or the patella is known as the sesamoid bone. There's also sesamoid bones in the finger and the feet, and the sesamoid bones are usually there for protection. So it's an area for which a tendon passes, and it prevents a relief, so to speak.
The patella acts like a fulcrum for knee flexion and extension, right?
Which what?
For knee extension, the patella acts like a fulcrum for the lever.
Oh, yes,
Yeah.
yes. Patella acts a fulcrum. When we talk about that, we will talk about that. But right now, when we talk about sesamoid bones, think of you standing up on your foot all day long and walking. There is a tendon on the bottom of the foot known as the flexor hallucis longus tendon. Flexor hallucis longus flexes the big toe. Inserts into the distal phalanx of the big toe. So it is separated on each side by sesamoid bones of the foot, on the plantar surface of the foot. It's a protective mechanism. Think of you running, think of you walking every day. You would be compressing this tendon and shearing it because over time it would shear. So these sesamoid bones are there for protection. Okay? All right. What is the definition of a joint? Something you did last night. No. A joint is an articulation between two bones usually held together by ligaments. That's the definition of a joint. Okay? There's other definitions, but this is the one we're concerned. All right? So where two bones come together, there's something known as a joint. We talked about this already. We said there's an OA joint. We said there's an AA joint. And joints are usually referred to from their superior or their proximal to their distal or their inferior. So the occipital atlantal joint is from the occiput to the atlas. The humeral ulnar joint is from the humerus to the ulna. Okay? So we have to know the names of these because how else are we going to know where the movement occurs and how to mobilize it if there's a problem? Okay? Types of joints and structure of joints, and there's another little nice diagram after this, but we're going to talk about the type, the motion, the structure, and give you some examples of it. Okay. So synarthrosis is structurally fibrous, it's a fibrous joint, permits no movement. Okay? This is what the A&P people say. They say the sutures do not move, but we PT people say they do. Because we PT people do something known as craniosacral work. And there's been some actual scientists and therapists that have looked with these microscopes that are extremely delicate and extremely powerful to see that there is a blood supply and a nerve supply throughout the sutures. So, do I believe the sutures move? Yes. My husband, who teaches anatomy, physiology, kinesiology, comparative anatomy, tells me no, because he's a scientist and he's not a therapist. All right, so, but when I do this on him, he said, oh, that feels really good. But he still can't concede that nothing's moving, it just feels good. Okay, but I have changed people's blood sugars by doing craniosacral work, so something's working, right? Something's working. And it's proven that there are blood supplies and nerve supplies. So, regardless of what they've been saying a million years, it doesn't move. There's some. I'm not talking about wow. I'm talking about, it's very, very slight. But the definition of a synarthrosis permits no movement, okay? Syndesmosis is structurally fibrous, and it permits a little bit of movement. Think of, and I'll give you a classic example for us, what we're looking at is there is a syndesmosis between the distal tib fib. All right? So we have tibia and we have a fibula, and we have an ankle, and we have a talus. And when we walk and we dorsiflex and we plantarflex, the foot comes up, the talus comes up. What do you think would happen if we didn't move that tib and fib? Somehow, some way. We probably wouldn't have much dorsiflexion. We'd probably be walking like this. So there has to be a little bit of movement that spreads the tibia and fibula, and that's known as a syndesmosis. Okay?
That's a high ankle sprain, right? High ankle sprain?
High ankle sprain involves the syndesmosis, yeah. Okay. Gomphosis is like a peg in a socket. It's also fibrous. Think of your tooth. Amphiarthrosis is cartilaginous. So we have slight movement. Pubic symphysis, think of women that have had children. Cindy can attest to you that pelvis did move, right? When she had 2 kids? Okay. So God forbid it didn't move. And you were my husband's mother who had 3 kids, 4 boys that were 11 pounds. That's gotta move. Right? It's gotta move. So we have amphiarthrosis, pubic symphysis, discs, ribs, amphiarthrotic. And finally, diarthrosis is what we're going to be concerned about when we talk about joints. Freely movable, okay? They're the most common. And we refer to the shape when we talk about their classification. So here, just remember this little diagram, okay? So if you think about that little test I might be giving you next week, and I say to you, describe the types of joints that are encountered in the human body. So you may list them for me, okay? Or give me an example of a fibrous joint. Yeah.
So what are we doing with the bones in the skull? What's the correct answer? For bones in the skull in terms of what type of joint?
Say synostrosis, yeah. Synostrosis, yeah. So joint capsules, this is a synovial joint, and this is very common to every synovial joint we have. We have a joint capsule, so that capsule covers, and I do have videos to show you what a cadaver dissection looks like, and I could show you that there is a lot of redundancy and a lot of movement in a joint capsule. The joint has to be able to move, the humerus has to be able to move in the glenoid where the joint capsule is, so there's a lot of movement that occurs there. So the joint capsule covers the articulating ends of the bone and holds them together, and it's usually made up of fibrous cartilage. Okay, fibrous cartilage is the strongest cartilage we have in the body. Synovial membrane will line the joint, and synovial fluid is excreted within that synovial membrane to nourish the joint as well as to lubricate it, such as, you know, if you're opening up a door and it squeaks, you need a little oil. So we need movement in a synovial joint in order for the joint to operate appropriately. So if somebody lays around for a long period of time, they get stiff. And this is what happens because the synovial fluid is not moving. So sometimes we need to do some little traction with them, or we need to do some mobilization with them, or we need to just get them up and walk. The bone is covered at the ends with articular cartilage. So articulated hyaline cartilage is covered at the end. The discs are pads of cartilage between the bones, the joint surfaces, and ligaments are dense white cords that once stretched do not regain their shape. So think about a six-pack of beer, some of you had on the weekend. Some of you had a six-pack of Coke. Some of you had Diet Coke. Some of you don't drink, some drink water, whatever. But think about that little plastic thing that these six-packs are in. Once you stretch them, what happens? They don't recoil. So this is kind of like ligaments, all right? So what do we have to do once we have a sprain of a ligament? We have to make sure that we stabilize the joint by making the muscles around the ligaments as strong while that ligament is healing, okay? Or if somebody's got multiple sprains, then you have a lot of instability. Okay, so ligaments. All right, so let's talk about joints specifically. A plane or a gliding joint. The joint will, the bones glide over one another. Think of that carpal, the carpal or the tarsal where they glide. A cellar joint is kind of like a saddle. So, metacarpal joint, both surfaces are saddle-shaped, and they fit into one another. A hinge or a ginglymus, all right, so carpal, metacarpal joint, right here. Here, you could see, where's my arrow? Oh, you could see here that one fits into the other. Okay, so that's the carpal, metacarpal joint of the thumb. Hinge or a ginglymus joint is just, yeah.
What was the first line? I'm sorry, I missed that.
That one?
Yes, thank you.
The bones just glide over one another with movement. Okay, cellar joint, saddle. Hinge, it's unidirectional. So think of the elbow, think of the knee. A pivot, one bone moves around a stationary axis. So when we talk about the arm, and we're going to talk about things like supinators and pronator teres and the supinator. When we think about the attachment for these muscles, they're always going to attach to the movable bone. The movable bone in the forearm is the radius, not the ulna. Okay? So this spinning that occurs, or this pivot that occurs is at the proximal radial joint is a pivot joint. Okay? Also the AA. Modified spheroid, they call them ellipsoidal, we'll call them condylar. Okay, it's the same thing. So a condyloid joint is a modified spheroid joint, and the reason why these are important, I'll talk to you about the range of motion that occurs at each of these joints. So a modified spheroid joint is a radiocarpal joint. And finally, ball and socket, that's pretty easy. So you have a ball that fits into a cup, that's a acetabular-femoral joint, and the glenohumeral joint. All right, here's the interesting part. So when we talk about joint classifications, we refer them by axis, whether they're non-axial, whether they're biaxial, whether they're triaxial, multi-axial, or non-axial. So non-axial is that gliding joint. It's linear movement, it's not angular, so it's just gliding, one bone gliding over another. So intercarpal, joints are flat. Uniaxial means you have one axis and one plane. Okay, so it's movement in one axis, one plane. So think of something, what is this? Flexion and extension, right? Flexion, extension. Are there any other planes involved in this besides sagittal? No. Somebody might say, well, you could do this, but didn't I say this comes from the proximal radioulnar joint, not the humeral ulnar? So the humeral ulnar joint is truly just a one-plane movement. One plane, one axis, uniaxial. Okay? Elbow, this too. Okay? Not this, because this also has this, doesn't it? But this, can you move your finger can you move your finger? Can this move anywhere else but this way? No. So it's uniaxial. So some of you are going to say, but I could do this. That's a different joint. All right, that's the metacarpal phalangeal joint, and not the proximal interphalangeal joint. That's why we have to know the difference in joints. Yes?
Just to make sure, like all these joints here, are they classified as diarthrosis?
Diarthrodia.
All these different.
Yes. Yes. Okay, so uniaxial, elbow, and interphalangeal joint. Biaxial, two planes of movement. Two planes, two axes. They're the condyloid joints and the saddle joints. So what do we have in the thumb? We have flexion, extension, ab, and adduction. All right? What do we have in the wrist? The radiocarpal joint. Flexion, extension, radial ulnar deviation. That's a condyloid joint. Okay? Triaxial or multiaxial. Three axes, three planes. Shoulder, flexion, extension, ab, adduction, internal, external rotation. Hip, flexion, extension, ab, adduction, internal, external rotation. Okay? So uniaxial, biaxial, and triaxial joints. That's the ones we will be mobilizing. Okay? So when we talk about these joint motions around these axes and these planes, they are referred to as degrees of freedom. So either something has 1, 2, or 3 degrees of freedom. So if on a plane, a gliding joint is only gliding. That's occurring at the wrist. That's those intercarpals, right? But a hinge joint occurs in a plane through an axis. So it occurs in one plane through one axis. So how many degrees of freedom does it have? 1. A condylar, or an ellipsoidal, that's the same term, has 2 planes of movement. It's movement in the sagittal plane as well as the coronal plane. So how many degrees of freedom are there? If we have flexion, extension, and radial and ulnar deviation. 2 degrees of freedom. Okay? So a condyloid joint has 2 degrees of freedom. Saddle joint also has 2 degrees of freedom. Remember we said the metacarpal phalangeal joint flexes, extends, abducts, adducts. 2 degrees of freedom. It also has circumduction, but that's only in 2 planes.
Yeah.
Right? So that's 2 degrees of freedom. Ball and socket allows for 3 degrees of freedom because we have flexion, extension, abduction, adduction, internal, external rotation. Okay? All right, and after this slide, we're going to finish because this is where it gets a little complicated. The ankle, there's movements that occur at the ankle. What are they?
Dorsiflexion, plantarflexion.
What else occurs at the ankle? What else do you do with your ankle? What do you do with your foot? You could dorsiflex it, you could plantarflex it, what else can you do? I mean, because some of you are runners and you say you overpronate, or you're supinators, so that occurs, right? What else? Inversion and eversion, right? Toes in, toes out. So you could run with your toes in, and that may just be from the foot, but it may be from the tibia, and it may be from the hip, and it may be from the pelvis, but we don't know until we examine someone, right? But all these motions that occur at different joints. So we have the talocrural joint, and they say cruel because it resembles a cross. The talocrural joint involves the tibia and the talus. Okay? Talus, the tib, fib, and the talus. All right? What is occurring at that joint? The talocrural joint is only dorsiflexion and plantarflexion. Only. The subtalar joint, which is under the talocrural joint. So subtalar means what? Sub is under, talar is talus. So the subtalar joint refers to the talus and the calcaneus. And the only motion that occurs there is inversion and eversion. Why is that important? Because if you're lost in an eversion and I mobilize your talocrural joint, you'll never get inversion and eversion back because I'm mobilizing the wrong joint. So you have to know. So we're going to be looking at bones soon, and we're going to be looking at where the talus and the tib-fib join. We're going to be looking at where the talus connects to the calcaneus. And where they do, that would be known as the subtalar joint. Now, supination and pronation, and you're going to say to me, how does this happen? This is really, really complicated. It's well past a 4-year degree. I mean, there's specializations in feet themselves, which refer to X, Y, and Z axes. So there's a lot to the foot, and supination and pronation occur in the mid-tarsal joint or the transverse tarsal joint. Okay? Supination and pronation occur in the mid-tarsal joint. Involve it's a combination of movements, and it involves the talus, the calcaneus, the navicular, and the cuboid. I'm sorry, the talus, the navicular, the cuboid, and the calcaneus, yes. So the talonavicular calcaneo-cuboid joint. 4 bones are involved in the mid-tarsal or transverse tarsal joint. Okay? The talus, the navicular, the calcaneus, and the cuboid. This is where we have supination and pronation of the foot. So if we have pronation of the foot and excessive pronation of the foot, the navicular drops down toward the ground and our foot has a flat appearance. Okay. If we have a supinated foot, the navicular is higher than it is normally, and it looks like the arch, it looks like a cave. You could actually see the difference in a supinated and a pronated foot. An overpronator is flat-footed, and a supinator runs on the side of their feet, usually on the 5th metatarsal on the lateral calcaneus. Okay? Why is that bad? Well, because when we talk about gait, you'll know that you have to have supination as well as pronation, because with a supinated foot, your foot is rigid, and with a pronated foot, your foot is more flexible. So that's really important to restore that. Now, pronation is a combination of dorsiflexion, abduction, and eversion. Okay? Pronation is a combination of dorsiflexion, abduction, and eversion. Plantar flexion is a combination of plantar flexion, adduction, and inversion. But, as I said, it gets more complicated because this is only in a non-weight bearing foot. Once the foot hits the ground, everything changes. Okay? You don't have to know that now. But I do expect you to know the definition of pronation of the foot, that the pronation and supination occur at the mid-tarsal joint, and pronation involves dorsiflexion, abduction, eversion, and supination involves plantar flexion, adduction, and inversion. Okay? I always remember DAB-E, D-A-B-E, DAB-E for pronation. If you remember that, then then the opposite is what supination is. It's PAD-I and DAB-E. So dorsiflexion, abduction, eversion is pronation. And you will see this also in people that walk. And as I said, things change when you walk, but the body's always going to, it's like electricity, it's going to follow the path of least resistance. So if somebody doesn't have dorsiflexion, they're going to turn the foot out. They're going to evert it. And so instead of walking over the foot, they'll walk around the foot. Right? I didn't dorsiflex, I everted. So just remember that. Okay? And we'll get into gait next semester. Yes?
I'm sorry, I apologize if this sounds like a question. But, so would supination kind of be like walking pigeon-toed?
You gotta talk louder.
Would supination be walking like pigeon-toed?
No, inversion would be walking like pigeon-toed.
Okay, so supination,
Supination is a combination of plantar flexion, adduction, and inversion. So your arches of the feet would be off the floor to really exaggerate it. You would be walking on the lateral side of your feet. So if you wanted to look at your shoes to see if you were a supinator or a pronator, your wear would be on the lateral heel.
I was just gonna ask that, yeah.
Yeah. Okay? Yes?
So that's for weight bearing, right? So the.
This is non-weight bearing. Non-weight bearing. Things change when you weight bear, because when your foot is on the ground, these bones don't move. There are some bones that move while the others do not. Okay, so we have really calcaneal eversion or inversion, and then we have the talus that moves. So it's a little different. But for now, know that in a non-weight bearing position, the definition of pronation and supination are this. DAB-E, dorsiflexion, abduction, eversion for pronation, plantar flexion, adduction, inversion for supination. That motion occurs at the mid-tarsal joint, at the subtalar joint is in an eversion, and at this talocrural joint is dorsiflexion and plantar flexion. Okay? These are really important. I'm sure some of you that work in clinics see your therapist hold on to somebody's leg and say to them, okay, move forward. So they're mobilizing the ankle joint in a functional position, but they're mobilizing the talocrural joint. So they're looking for dorsiflexion and plantar flexion. They're not looking for in and eversion. So this is why I'm saying these are important to know. Okay? All right? Okay, Thursday.